Our next speaker is Ron DePinho from the Dana-Farber, who is going to address a very important subject that all of us have been dancing around. Do we have better predictors for outcomes and prognosis in this disease than simply using PSA and maybe the Gleason score? Ron?
I've learned a lot this morning, and I want to tell you about a couple of things that I think is useful for this community to think about, and it's a bit different from how I think most are thinking about this area of cancer science in general. So one of the, and I want to cast a broader net initially, and I think some of the comments that were made really speak to some of the central issues that are important in understanding and treating cancers like prostate cancer. And the issue that I'll be talking about is the one of trying to manage more accurately early stage cancers. This is not just the case for prostate cancer. There's an enormous amount of progress that's being made in early detection. And right now, about 60% of cancers are diagnosed at stage 1-2. Most of those cancers are locally managed. Very few are proactively managed. In fact, most of those cases are not enlisted into clinical trials because of the enormous number of relatively benign cases. For example, in melanoma, about 10 to 20% of stage 1-2 cancer, so-called thin melanomas, are simply surgically resected, but about 20% of those patients will eventually come back to die of the disease. They have Kaplan-Meier curves that are essentially indistinguishable from other more advanced staged cancers, and this is true for virtually all cancers. So it appears that certain cancers, early stage cancers, are hardwired up front for lethal metastatic disease. And so the thinking here is that we really need to go beyond simple morphological analyses, which are important and instructive, and really try to ascertain molecular markers that will allow us to appropriately stratify cases into more aggressive versus more benign treatment regimens. And I guess the poster trial for this is prostate cancer. So I'll be telling you about some of the work there. I think following on some of the comments that were just made by Eleni in terms of understanding the progression of cancer, I think the thinking in the field has been dominated by the thesis that there's this stepwise accumulation of genetic events that endows cancer cells with an increasing number of biological capabilities that eventually reaches some threshold that enables metastatic progression. So that is actually not consistent with the clinical data, nor is it consistent with the genomic data. It is true that cancers are relatively plastic with respect to their genomes and their biology, so if you apply selective pressure, you can certainly acquire new events that endow those cells with the ability to do an end around any clinical intervention. But what we're talking about here are primary tumors, and primary tumors have a lot of their genetics hardwired in as soon as they traverse the benign to malignant transition. Our thinking on this was driven by the work that we had done in the 90s in telomeres, and as a result of this work, which I won't describe, we now know that very early on in the life history of cancer cells that you have these events in which you have telomere erosion. Epithelial cancers are the most common cancers in adults. Part of that relates to the fact that with epithelial renewal, inflammatory states that have high ROS conditions, they erode telomeres quite significantly and send cells into this telomere-based crisis phase, which creates chromosomal breaks. Chromosomal breaks enable for translocation events of the sorts that are seen in prostate cancer, and they also provide opportunities for regional amplification and deletion of the genome. All of that happens very early on in the development of cancers, so that at the point that you have, for example, DCIS in breast, KIN in prostate, high-grade dysplasia in colon, the level of genome complexity that exists in those, quote, early lesions is equivalent, if not more, than what you see in metastatic disease. And so this enables these cells to acquire the large number of changes needed for malignant transformation. Telomerase actually plays a role in quelling that instability, making the cells more healthy so that they can progress more readily. And there's a lot of genetic data, a lot of genomic data that now substantiates this. In the context of prostate cancer, we know from the work of Alan Meeker that when you have PIN, you already have a significant amount of chromosomal instability. you have erosion of telomeres, as he's shown, and this is just shown here on this telomere fish assay with PIN. You already have a loss of these telomere signals, which you can readily see in the normal prostatic epithelium. So there's a lot of telomere-based erosion that occurs. Telomerase actually comes on at later stages in the disease to enable progression. And so if you think about this particular paradigm, which we termed episodic instability, at this benign to malignant transition, you're essentially dealt wholesale changes in your genomes up front. And so if you happen to acquire a constellation of events that also confers mutagenic behavior, the ability to grow at distant sites, such patients will go on to progress and metastasize in terms of their upfront genetics, whereas others may enable local tumor growth but are not endowed with those capabilities. And so one of the challenges in prostate cancers in trying to discern those genomic events was already alluded to, and that is that there's a staggering amount of intratumoral heterogeneity, both on the biological level as well as on the genomic level. And this is thoroughly consistent with this enormous amount, this cauldron of change that occurs as a result of telomere dysfunction and other mechanisms that destabilize the genome. And so you can imagine that if you're trying to discern from this molecular signatures that might enable you to figure out which patients are going to progress versus not, it's extremely difficult. And so what we've done is to exploit the experimental merits of the mouse. And this is the work of Jeff Ding in collaboration with Terrence and Laura Limucci, who's at the Harvard School of Public Health. And so what Jeff did was to have this take advantage of a model system that was developed by Hong Wu and Pier Paolo Pandolfi years ago, which is the P10 knockout. This knockout generates high-grade PIN, but is never metastatic. It has a very feeble progression phenotype. And what Jeff hypothesized is that there may be, as a result of loss of P10, activation of pathways that might be constraining progression. And so what he did was to examine mice that were either P10 deficient versus wild-type prostatic epithelium, do unbiased transcriptomic analysis and pathway analysis to see if you could discern such a pathway. And this unbiased analysis identified 4 pathways, one that made sense, which was the PI3 kinase signaling pathway. It's knocking out P10, that makes sense. Another pathway that's been shown to be important in prostate cancer, which is P53. And then 2 other pathways which were not really worked on, especially with respect to the epithelium, which was TGF-beta and BMP signaling. And these were very robustly overrepresented in the transcriptomes. And then we looked to see if this was in fact, this in silico observation was in fact true. And what you see here is that SMAT4 and the P10 nulls, which is a key signaling pathway for TGF-beta in cells, was dramatically upregulated along with other components in this pathway. This is shown here also at the level of immunohistochemistry. This is a wild-type prostatic epithelium with no SMAD expression, and you see that when you knock out P10, you have robust activation of SMAT4. We then turned our attention to human specimens and Oncomine data and could show that in fact almost all of the metastatic prostate cancers in humans have extinguished SMAT4. About 10 to 15% of primary tumors show low expression of SMAT4. And this is just Oncomine data showing that relative to primary disease, the metastatic disease universally downregulates SMAT4. Then Jeff did an additional initial study, which was to knock down SMAT4 in the one cell line, PC3 human cells, that still have an intact TGF-beta signaling axis. And that showed that in an orthotopic setting, that you can have increased metastatic potential of these P3 cells, that there's a metastasize to lymph node and to lung more readily. So that gave us some confidence that we were perhaps on the right track, that SMAT4 might be important for the biology of prostate cancer. But he wanted to look at this more rigorously, and he did a genetic experiment which he knocked out SMAT4 in the prostate. This is a conditional knockout, and there was no phenotype with an inactivation of SMAT4 only. These animals have been followed for well over 2 years. However, when you do the double knockout, SMAT4 plus P10 versus P10, what you see is that all of the animals of the double knockout are dead by 32 weeks of age. And this is just a side-by-side comparison of the tumors. This is a double knockout versus the P10 nulls, and they have highly invasive prostate cancer. If you do a serial analysis of the single versus the double knockout, what you see already by 11 weeks is invasion through the capsule, as well as by 15 weeks, very florid adenocarcinoma with a very nice, robust stromal reaction, etc., which nicely recapitulates the human disease. He also looked for evidence of metastatic disease, and 100% of the animals had metastasized, and where they metastasize is primarily to lymph node and to lung, as shown here by AR-positive, CK8-positive lesions in the lymph node as well as in the lung. So we had generated a model that appeared to be quite active in progression, and then this then set the stage for us to look at more carefully what was it about SMAT4, what kind of biology was it regulating in the progression of prostate cancer. I'd already shown you that there was increased invasion. The other thing that we noticed is that there was more S-phase entry. There was a more robust proliferative activity in the context of these double knockouts. And we also showed that there was deactivation of a process that was originally identified by Pier Paolo Pandolfi of oncogene-induced senescence. That is when you acutely inactivate P10, the cells react by incurring a senescent response. And if you inactivate SMAT4, you see that this senescent response is significantly deactivated. So this then set the stage. We had a clean genetic system in which we can do an extreme case analysis. So we have animals that are 100% metastatic, the double knockouts versus 100% non-metastatic, take equivalently early stage tumors and ask what do the transcriptomes look like, and can we use that information to gain further visibility on what's going on in the human situation. And we did this unbiased analysis. Again, there were about 300 genes that were different between the double versus single knockout, and we then did an analysis of the functional categories of those genes, and the top two functional categories were cell movement, consistent with that invasion that I just shown you, as well as cell proliferation. And you might argue these are just normal cancer-relevant activities, but we did the exact same study with P10p53. That also gives a very aggressive local tumor, but it does not metastasize. And so looking at this, there was a much lower representation of cell movement, which was 17th on the list, and the the p-values are much, much lower on this scale than on the previous scale. So there was something very special about SMAT4 that was commandeering mutagenic behavior of the cells, proliferative activity of the cells, and we wanted to understand what was it that SMAT4 was regulating at the molecular level that would enable us to understand this more accurately and perhaps use that information to guide us on the human side. And so the model is that SMAT4 is a very important checkpoint for progression in prostate cancer, and the clinical relevance is now what I want to talk about. So one of the first things that we did was to use the Glinsky data set. The Glinsky data set has about 80 cases, around 7 or 8 metastatic cases. It's got biochemical recurrence only, but we wanted to first assess whether or not the double knockout transcriptome, these 300 genes, could dichotomize patients into more aggressive versus benign disease. And what you can see here is that the high-risk group that these two cases, these cohorts, could be stratified into high and low-risk groups as a result of this 300 gene set, and all of the metastatic cases were in the high-risk group. So that was encouraging. And also, just to nail the importance of this transcriptome, we did the same exact thing with the P10p53 transcriptome, and that was not able to dichotomize the patients. So that suggested that embedded within those 300 genes might be genes that could be helpful in identifying which patients might be hardwired for more aggressive disease. So I'm not going to go through an enormous amount of data that Jeff did, but essentially what we did to go through those hundreds of genes was to use certain criteria that was actually informed by the biology I told you before. They were more proliferative, they were more invasive, so we wanted things that were reporters of those biological processes, because that's what the tumor biology was telling us. We also wanted more direct targets of SMAD4, so we asked that there be SMAD4 as a transcription factor. We wanted things that were directly regulated by SMAD4, that were more proximal, since we knew that that was an important genetic element. We wanted it to be reflective of the tumor biology. We wanted it on the functional level to drive the tumor biology in these human cells, that when you overexpress it or knock those genes down, those genes would confer this enhanced metastatic potential. It had to be altered strongly in the mouse as well as in humans, and it had to have superior added predictive value over Gleason scoring and clinical parameters. So that's what we did, and the exercise was to take about 100 genes that were filtered through expression studies in humans, packaged them into lentivirus, then did a variety of surrogate assays for invasion and proliferation, looked for direct targets, looked for progression-correlated expression. In human prostate cancer, we got down to 2 genes. One gene, which was important for invasion, which was the top score, was SPP1, and the other one, which was very important for its proliferative activity, was cyclin D1. And we looked at all of the G1S regulators. It was really something special about cyclin D1, not even D2, which was able to commandeer the proliferative activity of prostate cancer cells. P27 was not correlated, P21, etc., but it was cyclin D1, as you can see here, that was significantly, robustly upregulated in the context of the SMAD4 deficient tumor cells. And we then assessed that on the functional level, and what this graph is simply showing is that enforced cyclin D1, in contrast to manipulation of the other elements, really dramatically enhances the proliferative activity of xenograft tumors from the PC3 cells. We then looked at SPP1, and we in Boyden chamber assays to look for invasion and mutagenic behavior of the cells. If you knock it down, you show that you have decreased invasion. If you overexpress it in cells that have a feeble invasive phenotype, you can enhance invasive properties. This is in vitro. We also showed this in vivo in terms of metastatic potential. So SPP1 appears to be a very robust regulator of invasive potential, mutagenic behavior of prostate cancer cells. I'm not going to go through this data in detail, but using a variety of reporter assays as well as in silico and biochemical chip assays, we show that cyclin D1 and SPP1 promoters are in fact regulated directly by SMAD4. There are binding elements that sit on those promoters, those cis elements, and can repress transcription of those genes. And when SMAD4 is missing, those genes get upregulated. Interestingly, it's the exact opposite in breast cancer cells, where TGF-beta actually plays a role in progression. In the context of breast cancer, the same binding of SMAD4 has the reverse effect on gene expression. So there's a lot of context specificity with respect to the signaling in this pathway. So the next step was to ascertain whether or not this is relevant to the human situation, and here we collaborated with Lorelei Mucci, Mira Stanford at the Harvard School of Public Health, the Physicians' Health Study, which has been around for several decades, in which you can follow prospectively cancer-specific deaths. There were 166 cases that at that time they had examined mRNA expression. They also had TMAs available, and there was very rigorous Gleason scoring by these very gifted academic pathologists. And so, as you know, there's a lot of variability in Gleason scoring out in the community, and so this is the best possible Gleason scoring that you could generate, in my view. So the first thing to do was to just ask, okay, we have a 4-gene set, and the 4-gene set in this case is P10, SMAD4, and the 2 genes that I just told you about, SPP1 and cyclin D1. And we asked, how does that 4-gene set rank in predicting lethal outcome in the Physicians' Health Study relative to 244 molecular signatures in the BRO database? And this ranked number 1 of the 244. So the possibility that this is by chance alone is close to 0. So this suggested that we had a signature that might be potentially useful. This is at the RNA level, and as has been pointed out, the enormous heterogeneity is a challenge in really assessing the quality of any particular signature, and so we opted to go the route of protein and immunohistochemical analysis to quantitate these genetic elements, these proteins, in tissues. And there we looked at TMAs, and we compared it to Gleason scoring and so on. The C statistic in the Physician's Health Study, and this is now 38 lethal cases and 367 indolent cases that were TMA'd, and then Gleason scoring only gives you a C statistic of 0.77, that the 4-marker set at the protein level gives a C statistic of 0.83, and the two together give a C statistic of 0.88, and I don't have the data, but with clinical data it goes to 0.92. So this is a very significant advance in the predictive potential of identifying which men are actually going to die from the disease. And I think this also tells us actually that Gleason's is capturing some biology that is not captured by the 4-marker set as well. So I think there's still room for improvement. There are additional markers that I think need to be identified so that we can really further enhance the predictive potential of any test that would go forward into clinical practice. And this is just a representation of what we see on the TMAs. You can see that there are very significant differences with respect to SMAT4 in low versus high risk, and changes that occur at the level of cyclin E1 and SPP1. And this is just a representative example. And so I think that this is providing us with opportunities to further enhance the management of cases. Now, we have to keep in mind that these are radical prostatectomies. These are not biopsies. We have not addressed the issue of having these markers really dichotomize men at very early stages in terms of diagnostic intervention. But I think with all of the advances that we just heard about this morning, I think this opens up the opportunity that we could potentially be more proactive in those men that are hardwired for lethal activity, and this may expand the opportunities for some of the agents that we heard about today. So this is just an example of how we've exploited the experimental merits of the mouse and genetics to discern a pathway that we think is now important for human prostate cancer, the TGF-beta SMAT4 signaling axis. We have shown that we now have a metastatic prostate cancer model that's quite robust. I want to emphasize that that we did not discern any bone metastatic disease, so there are clearly additional genetic elements that are important for that biology, and that it underscores the potential of using comparative oncogenomics, genetics, to identify and tackle some of the complex issues that are occurring in human cancer in general, particularly early stage cancers, which I think is an extremely difficult challenge for us going forward. And frankly, I would argue that this is going to be the frontier in the decade or two ahead as imaging advances, and this revolution in serum proteomics, et cetera, is going to give us not 60% of cancers, but the vast majority of cancers are going to be presented very early. So the problems that we now have with prostate cancer because of PSA are going to be the same for virtually all cancers. And so this is something we're going to have to be much more proactive about and really try to manage these cases so that they actually don't overburden the healthcare system. Right now we spend at least $500 million a year in unnecessary interventions in prostate cancer. It's just one cancer. And I think that's driven largely by the PSA use. The challenge at this point is going to be even more so as we start diagnosing a lot of other solid tumors with greater and greater precision. And finally, I want to acknowledge a gifted postdoc in the lab who's achieved escape velocity. So if you want a really good postdoc, this is the person. Jeff Ding, Terrence Wu, a gifted computational scientist, and I mentioned the important contributions of Lorelei Near-Stamfer and Max Loda as well, who is very important in enabling the TMA studies that I showed you. Thank you very much.
Ron, that was Terrific, and it was a great compliment to all the clinical work, because we clearly need a better understanding of how to pick out the losers in this field of vast numbers of patients. I know that there must be questions. Marty.
Yeah, that was terrific work. Just a question on an additional point of detail. Do you have an idea of the prevalence of the individual for SMAT, the P10 knockout? Of course, that's been studied before, but the SMAT loss and then the other two molecules loss, what the prevalence is in those early stage cases that were evaluated?
Yeah, so that's a very good question. So at the level of advanced disease, virtually all of those cancers show lack of expression. About 10% of those actually are the result of genomic deletion of the locus, but the vast majority are due to methylation. And when you look at just expression in the early stage cancers, about 10 to 15% show low levels of SMAT4 expression. Suggests, we don't know, but possibly those are the ones that have gone on to really progress. Now, that's a retrospective analysis of Oncomine data. We don't have the clinical data for that. But that's a very broad analysis of 6 different data sets suggesting that at least its rite of passage for progression to metastatic disease has to go through extinction of SMAT4.
I have to ask one burning question. Does all of this have anything to do with androgen sensitivity?
Well, I think that that's an area that we're very interested in assessing, because AR is so fundamental to the biology of prostate cancer. So any pathway that you discover that is relevant to the biology of prostate cancer has to be viewed through the lens of AR biology. Right. So I don't know.
Just not
I don't know.
At this point.
Yeah, exactly.
Okay. Eleni?
I have a couple of questions. I would assume that your standard deviations within and across the samples were very low, giving absolutely within the group.
Yeah, and I also want to emphasize that this was done quantitatively. It was done by, imaging, quantitative imaging. Yeah.
Assumed, but then I would like to point out that that is not the same with androgen receptor expression in that primary, and you probably...
Okay, that's a good point, yeah.
It's completely different. You have a lot of level of heterogeneity within the primary tumors, completely different from metastatic disease. But going back to what you mentioned regarding the metastatic potential of these diseases, which you pointed out, was there also a subset that you analyzed for that locally advanced disease that we sometimes get and not metastatic?
We haven't parsed that out yet. There's all these sub-studies that we want to now embark on, looking within certain Gleason's, categories, so on and so forth.
Final, quick question. Do you think we should apply it to the CDC technology, or are you good just with primary? I
think it's certainly worth looking. I think the challenge there, just from what I've learned about cancer genetics and biology in general, is the enormous amount of change that occurs at the transcriptomic level when you have cells in different microenvironments. Very dramatic changes that occur that are, literally hundreds, if not thousands of genes that change. So it's possible that if you really have the core elements that are responsible for driving the disease, that would be a way to look, and I would urge looking at genetics and genomics, not necessarily transcriptomics, which is subject to the varied winds of, microenvironment.
Chuck?
Chuck Drake, Johns Hopkins. That was wonderful, actually. I was wondering, given that 4-gene signature has such power, are you of the impression that these are independent events, or do you feel there might be an upstream process or driving?
I think these are the drivers and proximal to the biology, and that's how we screen for it. That's the 2 slides that I went to very, very quickly. Given cancer's complexity, no one marker will ever tell you what, captures the full biology of any particular tumor. So clearly, based on the tremendous amount of genetic, the backdrop of all the change, etc., the reason why we need multiple markers to really have robust predictive potential for any biological process is the fact that there's an enormous amount of context specificity that influences any specific gene. And so, I would imagine going forward that at some point one would need, a constellation, a small constellation of drivers to really inform as accurately as possible the biology of any particular biological state, cancer or otherwise.
I have to ask one other question, since I asked the androgen question. What about the immune system? TGF-beta and
Very
SMAT4
important,
must
yeah.
be influencing immunogenicity.
Well,
of
there's no
this.
question, obviously, very important in all sorts of processes that are relevant to immune regulation. We haven't looked at that, but I would be shocked if there wasn't a significant overlay in influencing the local immune responses in a way that's quite profound. And it's actually been shown that TGF-beta signaling plays a very important role in the stroma of prostate cancer. Some really excellent work from Vanderbilt in years past has shown that you can dramatically affect prostate cancer biology by manipulating genetically the TGF-beta axis in the stromal compartment. So that's just the stroma. The question is, what's going on in the immune system, and I would be shocked if there wasn't some influence.
Okay. One final question, Oliver?
Real quick, Oliver, sort of two lanes. So you've alluded to the genetic heterogeneity, and Roel Chennai and others have shown the Tempus-2 erg and SPINK1 and other such potentially chromosomal drivers. And have you looked in any way to integrate your signature with those genomic alterations? It seems like it's a marriage made in heaven to me.
We are doing that. We don't, I think, still at this point know truly whether or not the ETS translocations are more important for initiation versus the progressive potential of the cells. So I think that's one important aspect. But certainly any major genetic element that drives the biology of prostate cancer has to be integrated into this. There is some nice work that's been done across the pond in looking at whether or not ETS translocations and PTEN status might enable predictive potential and so on. And there's some preliminary data that suggests that looking at those genetic elements does inform the aggressiveness of the disease, but not examined at the level of lethality.
Thank you very much, Ron.